Well, Davin, today's guest is a real treat, a good friend of ours back from the Occidental College days, who shares our enthusiasm for lifestyle medicine and overall optimal performance. And he shares some really interesting insights. What did you find fascinating about Rob's interview today?
Well, I think it was fun to walk down memory lane a little bit, and how we all majored in kinesiology in college, and how he's actually using that in a very unique way. You know, that training, dating back to, his Eastern, journey and bringing back some of the Eastern medicine and doing acupuncture, at least having skill in that is really cool to see. And I think what a great application of functional medicine, pain management. So I think this will be a real treat for our listeners today.
Yeah, I love that he touched on the topics of burnout, of having a mentor, and how critical that was for helping him accomplish. I think also just really following his passion for educating and teaching. And I really, really was inspired by his story today. So I hope you guys enjoy it as much as we did. And we look forward to you listening to our podcast with Robert Bonakdar today. Welcome to the Root Cause Business of Medicine podcast, where we explore what's broken in healthcare and what we can do about it. I'm Dr. Erik Lundquist, and I've been practicing functional medicine for the past 15 to 20 years. I'm excited to co-host this podcast with my brother, Dr. Davin Lundquist,
who's just beginning his journey into functional medicine. We come from different points on the path, but we do share a common goal. We want to rethink how medicine is practiced and help others do the same.
The U.S. healthcare system is in crisis, rising costs, declining outcomes, and physician burnout at an all-time high. But we found a different way, another way, a better way.
On this podcast, we dive into real stories from medical professionals who've stepped away from the traditional model, kind of like me, and have found a new purpose in integrative, functional, and alternative approaches to care.
These are authentic conversations with practitioners and friends who've redefined success, not just for themselves, but for their patients and communities.
Whether you're a clinician feeling stuck, a student seeking direction, or just curious about what is possible,
you're in the right place. This is the Root Cause Business of Medicine podcast. Welcome back to another episode of the Root Cause Business of Medicine podcast. And today we have our special friend and Occidental alum, Robert Bonakdar, who we are super excited. He is the director of the Pain Medicine Center down at Scripps Integrative Medicine Center, and is fully capable of putting a acupuncture needle in any place that could benefit you. But we're excited to hear Rob's. Exactly. We're excited to hear Rob's story today. It's a little non-conventional, and I think we're all going to really be excited to hear what you have to share with us today. Rob, let's start off a little bit by just having you give a little bit of a background, kind of, how you got into integrative medicine, and then what kind of led you to the Scripps Center for Integrative Medicine, and even your time that you spent in China, learning acupuncture and traditional Chinese medicine. I think that'd be great to just kind of get that background story.
Yeah, no, thank you for that opportunity. Well, first of all, I don't think there's enough Occidental podcasts, so I hope you send this to the dean to let them know what you're up to. But I've been asked that question before, and I've talked to other integrative providers like my mentors, like Dr. Guarneri, and so I feel very lucky. Number one, it doesn't come from I'm on the cliff, I'm about to burn out. Although I've certainly, like every clinician has felt parts of that, but it didn't come from a place like I got to save my career and soul. It comes from, I was very, very lucky growing up. We had a family doc. This is going way back in childhood, back in Tehran, Iran, where I was born. I just remember these images of somebody coming to our home and being so kind to my family. I remember my brother having because of the part of the world we were at, it was he had like a Hep A, something he ate or drank, and he had to get an IV. And this person was just so like, wow, this is like an angel, and also knew my family as friends, and that was sort of this model for me. And then when I kind of went into college, I kind of knew I was going to healthcare. I had a few other mentors kind of tell me about family medicine. So that was in the back of my mind. That's the kind of doctor that does that kind of work. Then I got this opportunity in talking with Dale Wright, one of our great professors at Occidental. Hey, you seem really interested in non-US models of care. Why don't you do this Richter Fellowship? So it was a 1992-93 opportunity to go abroad, and you set your course. So I wanted to go to Singapore because they had blends of Eastern Western medicine. They had the English language, so it wasn't as much of a barrier. But also jump to Southeast China, Malaysia, Bali. It was just an incredible opportunity. I got to learn acupuncture, go more in depth with my study of Tai Chi and meditation, and it just felt like, wow, this opportunity is going to change my life and my career. And so when I got home, I was still pre-med, and I pretty much realized that was kind of, that was not possible. Like, you have to apply, you do the MCAT, you can't just go into that. And so reality set in. I still tried to keep up with, the meditation and the Tai Chi just for myself. But over time, all those ideals kind of got kicked out. You go to med school, you have to cram, you have to just put in the work and the sweat, and your whole entire life gets turned upside down. And if you're married, like I was, trying to balance with family, it's just ridiculous. And at a certain point, I remember talking to my mentor. My third year of med school, had a mentor, Dr. Millman, in Reno. I went to University of Nevada because I'm from Nevada, and he was very open with his use of integrative medicine as part of family medicine. At that point, we called it alternative medicine. He was talking about herbs. He was talking about my language, which I had not really felt for a number of years, having gotten Western medicine shoved in a good and a bad way. I needed the education, but we all know how stressful it is. And he said it's very doable. You just need to hold on to it until you get to the point where you can bring it into your exam room. Now, this is not your exam room yet. You still got to do what other people want. You got to do surgery and trauma and all that stuff, and deliver babies and all that, and then you'll get there. And so that was an incredible, I get chills thinking about it, because if I hadn't had that, like many docs, they want to go in that route, but they feel like there's no doorway here. And so I just got to do what I'm told. So that was another part of the story. And I'll fast forward to when I was finishing my residency at Sharp Grossmont across town here in San Diego. I had started on my own acupuncture clinic in my third year. I didn't have any mentors, but we knew we had a lot of low back pain. We helped a lot of the East County construction workers, a lot of folks who were doing manual labor, a lot of low back pain, a lot of folks coming through our clinic, needing Vicodin and needing this and that. And they say, well, if you want to do acupuncture, great. These are all the patients we don't want to see. You can go for it. And I was just loving doing that. I was also treating the nurses. They loved it. It helped their stress. And then residency was about to end, and they're like, well, we have nowhere to place you. There's no place for you. So good luck. And then I remember seeing a flyer for a labyrinth-walk lecture across town here at Scripps, where I'm seated right now. And I told my wife, I would post-call, I see this flyer. I was like, I don't even know these people. I don't know what a labyrinth-walk is, but I got to go. And she's like, are you sure? I was like, yes. I got to drive from La Mesa to La Jolla in rush hour traffic. I don't know why. I showed up there. I met Dr. Guarneri, who's a luminary in integrative medicine, interventional cardiologist, who also went in integrative medicine after a health crisis of hers. Would be a great person to have on here. And she said, hey, Rob, what brings you here? And I said, I'm not sure, but, I kind of want to meet you. I want to see what's going on here. I'm looking for a job after your residency.
Get right to the point.
What's that?
Get right to the point.
Get right to the point. I need a job. And she goes, what do you do? And I said, well, I'm a family doc, but I do acupuncture. I do, some of these Eastern things. He goes, that's great, because I'm a cardiologist and I have a whole bunch of heart patients who can't take anti-inflammatories and have heart issues. So do you want to do a fellowship here? I'll make it happen. We don't have an integrative fellowship, but I'll make it happen. And so within a few months, I graduated from residency. I land here, and my job was to help her cardiac patients. So I was helping with cardiac rehab, loving that, lifestyle change, stress management, diet, but also setting up what would become the Scripps Center for Integrative Medicine pain program, which now I was a one-man show doing acupuncture, this, that. Now we have, 3 acupuncturists, we have mind-body therapists, we have dietitians. And so I feel blessed to be in the right time in the right place. I'm still not sure what the labyrinth was. I did a labyrinth walk, like I know you did. And somehow it brought me here. So
that's awesome. I love that we have, not just our undergraduate connection, but we have these other points along the way. And, like your situation, I was completely disenchanted with the conventional medicine approach. And had it not been for a family physician whose name I don't even remember, talking about integrative medicine at the AAFP's medical student resident retreat or conference that they had, and he just happened to be speaking on integrative medicine. I go, oh, okay, there's hope for me, right?
Yep.
What do you think? I'm curious to hear. It sounds like the influence of both that initial experience in your hometown in Tehran, as well as your exposure to the breadth of medicine approaches in the, Asian Eastern areas. How did that really kind of shape how you're practicing medicine now?
Great question. I think the key thing it did for me was demonstrate that blending those things is possible. Like the first example was, you don't, as a family doc, you don't need to be stuck in a environment where you're just, seeing a million patients and not really getting to know them as a person. You can. So that was one of the things I really liked thinking about as a future doc. And in Asia, I got to go to the Richter Fellowship, and I've been back to Taiwan, actually, with a contingent from the Cleveland Clinic, where they have a big traditional Chinese clinic within their integrative medicine, to see that in a hospital outside of America, especially in Asia, the two blend together. So somebody's going in for surgery, they see the surgeon who's often trained in the United States or somewhere very reputable. They're ready to do their magic, and then somebody else might come in who might be a Tai Chi practitioner, or Qigong practitioner, or traditional Chinese, just to sort of give the full scope of how we're going to support you. And for me, I always felt like it's one or the other. At least in med school, like, yes, that's alternative medicine. Your patients will go after that. If they do, there's something wrong with them, and just don't ask too many questions, and try to dissuade them, all those things. And he was a model where it was the best of both worlds, best of high touch, best of high tech, and best outcomes. So bringing that back, I kind of felt like, no, over time, that's possible. When I landed at Scripps, I had a mentor who went to bat for me. And I think we'll talk a little more about, how this all works, but having leadership that really says, I don't quite understand what you're doing, but if it gets good outcomes, I'm going to back you up. And I had that. And I think blending is something that we, unfortunately, with functional medicine, with nutritional therapy, you often feel like, no, we got to do the medications, we got to do the procedure, and there's no room for the other stuff. There absolutely is room. And I saw examples of that, and I was supported in that. And I think many folks aren't. And I think that's an unfortunate. Like, you started getting support or thinking, wow, at the AFE retreat, you were lucky to get that. Like, you saw a model of the future, and you were able to kind of go in that direction. And I think we don't have it. I mean, now we have more, but I think a lot of docs are still don't see that. They don't have that vision, unfortunately. And so they're stuck until it becomes too late.
Yep, I totally agree. And it was interesting when I was in Taiwan giving a presentation a couple of years ago, and I asked a question. I was curious, right? So I asked the whole group, there was probably, I don't know, 200, 250 practitioners, most of which were physicians. I said, how many of you practice some form of traditional Chinese medicine in your practice? And I got 10 hands that were raised. So I think it's interesting because culturally they blend the two of them, but still they compartmentalize very much their approach. Like, I'm a Western medicine doctor. And this is a traditional Chinese medicine doctor. And there's a big line. You don't have a lot of practitioners. So it was really interesting. It was a functional medicine conference that we were teaching. And so they were just, they couldn't get enough. They were just sponges in just taking this in. It was so interesting. Philosophically, they had some comprehension, but training and education, they hadn't.
Yeah, no, first of all, I remember you going to Taiwan. I was very jealous of you because any opportunity I can get to get a free trip. But I do recall, like in the hospitals in Taiwan, like you would have a floor, a surgery floor, you would have the PT floor, then you would have like the traditional Chinese medicine floor. Like, so here in the United States, we don't even have that floor with, traditional Chinese or functional medicine. Rarely we might, but most of the time it's very conventional. If you want to do the other stuff, it's after we're done with you. But you're right, even within a realm where they accept it, there are these silos. And that, again, we can try to optimize it to find ways to integrate that. But I think in system, it's very hard to know how do you bill, how do you chart if you're doing multiple different types of medicine. So I think there's work to be done everywhere. But I think one of the key things is in the United States, we don't even have a lot of those non-conventional things embedded in our clinic or hospital. So to us, they don't even really exist, and that's unfortunate. It's sort of on the outside periphery for the patient to find, and it becomes fragmented, right?
Yep.
I think, another thing that kind of jumps out to me is thinking about, like how does it get reimbursed? And did you notice, in the Asian model, how that reimbursement worked? Is it like state funded? Are these people employees of the government or something? Or like, how do they both show up for a surgery and then like their time is accounted for? I'm kind of curious.
Sure. Well, I think that's a really good question. And I was blown away because sometime in the 90s, actually, Taiwan was losing a lot of money to their medical system. And we obviously, for many reasons, waste, paperwork, bureaucracy. The United States has a lot of waste and loss of money. That's not really for care. It's sort of the periphery of care, or not even anything to do with care. But in Taiwan, they were seeing that. And what they actually did, because they had a national healthcare system, which again, arguably is harder to do in a larger place like the United States. But basically, they came to the United States to get medical and financial experts and come look at our system. So they revamped it and they said, basically, we're going to give people health cards. So, and expand preventative care. So within not even a generation, within 7 years, and there was an article I wrote about this, like how amazing that they took the brain trust that we have here, took it over there and said, how do we make this better? So start covering dental, start covering acupuncture, start covering, manual therapy. And conceivably, you'd say, well, that's all this cost. People are going to overuse it and this and that. But really, over time, patients, it evened out to the point where it increased lifespan, increased quality of life, reduced preventable causes of morbidity and mortality, using American knowledge. So when I came back, when I think about it, I was like, how can we not do that here? At the same time, I know why we don't, because the turf is much more convoluted and much more fee for service, et cetera. So that's how they did it. They have a health card. So I literally see people go to the hospital, they swipe their card, they go see the dentist, they go see the surgeon, they go see the traditional Chinese doc. And it's not like a menu that you're going to overuse it, because at a certain point, you got to get to work, you got to, go to school. So you use what makes sense for you and helps your health.
Yeah. No, I love that. I mean, in my roles in a large health system, even as a technology person, one of my initial tasks was to try to find a population health system, right? And so, I became sort of comfortable with understanding the difference between fee-for-service and value-based care. And, this country has been threatening, I say threatening because, to move to value-based care for decades, right? And it seemed like the whole time that I was there, we're like, okay, we're moving. And then we never really moved, right? We dabbled. We tipped our toe into the water. And it is a challenge, I think, to go, to make that shift. So it's just fascinating to hear that, maybe a smaller country that's a little more, invested in terms of like everybody was under one regime or something. But yeah, it's fascinating.
One thing that I would say to that also is that it is very hard to do that in the United States as a population, but there are like visionaries like Dean Ornish, for example. He said, as an internist, heart disease is multifactorial. In addition to doing catheterization and surgeries, we should be doing, stress management and exercise and dietary shifting. And so he created that in his clinic, and that was one of the first things we did. We actually got started. I say we, but Dr. Guarneri got a grant from Ed Bakken, founder of Medtronic, who is, I believe he's passed, but he was a big fan of integrative medicine and preventive care, even though his whole realm was about technology and pacemakers and all that. He gave a starting grant for us to bring the Ornish program into Scripps as it went to multiple centers as a pilot project. And again, just like value-based care kind of was hot for a while, so was, doing these pilots in your setting. And he did that pilot, and now there's been enough of that Medicare covers some aspect of the Ornish program, but we don't have enough examples and enough conditions so it's still sort of these little pods of potential, but not enough to help the people that really need it across the.
Well, and the reason I bring it up was because you described a scenario that struck me as, well, how did they pay for that? So, because and the other reason I think it's interesting for our audience is that, to me, telemedicine's like a really good use case where before the pandemic, as a technology innovation officer, I was pitching telemedicine to our board of directors, right? And they were sort of interested, and they were trying to make it happen, right? But until it became a funded initiative, right, where now you will actually get reimbursed equal to an in-person visit, it took off, right? So it wasn't a bad solution. It just hadn't really been the incentives weren't aligned, right? And so I think part of our challenge in this space is understanding, right, those incentives and the financial market and the model, because if we really want to see this take off, and we all understand the value of what's happening here, there needs to be a bigger financial model aligned with it. So I'd love to hear your thoughts on that, especially since it sounds like you guys figured something out early on.
Well, I think I had the same thought pre-pandemic. I believe telemedicine and some of the technology aspects should have been incorporated way before we had to do them. And I had a similar discussion with my folks saying, there is technology here which wasn't anywhere near where we have today. Like, why can't we do video visits? Why can't we do group video visits? They're doing them at Cleveland Clinic. And they said, no, it's too costly. We have to buy this module. And then suddenly, a few months later, we had to use it. And so I had the same experience. So sort of until there's an incentive, financial or otherwise. So I think the closest thing we have now, which wasn't my model, our model was figure it out as you go along. I think I remember, Erik, in your session talked about, like, in your clinic, you used to have massage therapy. We had massage therapy until it didn't get reimbursed anymore. But we still do things that are reimbursable. Like if somebody doesn't get acupuncture coverage, I do a trigger point. It's close enough and it still has benefit until I can figure out how to get acupuncture. They may not get, dietary visit. So I might, set them up with my nurse to kind of help along the way. So we try to figure it out along the way. I still do a lot of traditional procedures in cases where the complementary therapies are not covered. But it's getting better each year with things like acupuncture, Medicare covering acupuncture. But the closest thing we have to the Orange program, which was, around, was a PCORI grants. You do these pilot projects. I wish there was more funding for that. Obviously, a lot of funding is up in the air. But if you or I have this yearning to help a population with whatever preventative issue or chronic, we should have the funding to say, let's do a pilot project, and it may show cost savings, it may show risk reduction. But unfortunately, those are rare to be able to access that. So most folks have to hustle, as we all have, to say, okay, I'm going to try this therapy, but I don't know if it's going to get reimbursed. So I'm going to do this other therapy, which I know will get reimbursed. And I think that's one of the key things I don't like about our system. It's you have to do more to get more. And it should be, how can I get more reimbursement for just being with the patient, getting to know them better as a human? And unfortunately, there's not a code for that. Closest thing we have is group medical visits, which I'm a big fan of. I know you guys are, but not every model is yet comfortable with that, or reimbursement model. So I think we're still trying to figure out how to get to a point where we're not just like, I have to diagnose you, so I have to give the pill to the ill or the needle to the ill. And patients figure that out, like they're getting over medicalized. And that's why they're going, I think, to other types of care where they feel heard. And that's why medicine, I think, in many ways is shifting, and we're losing our patients to models that make more sense, honestly.
Robert, maybe you could speak a little bit to what it's like, and maybe tell us a little bit about what the Scripps clinic or the Scripps environment is like for people who aren't familiar with it, because it is. You don't have, this isn't your clinic, right? This is a clinic that you have kind of established within a system, but you're governed by those who make decisions about what's going on. Maybe talk a little bit about how you've navigated that system, and would it be considered an academic setting? I mean, it's not really a university, but I know there's a lot of research and stuff and grants that are being given to Scripps. Maybe speak a little bit to that.
Sure. Yeah, I think for me, as I was finishing residency, number one, I was looking for a job. So, luckily this worked out better than McDonald's. But to be fair, I was looking for something that was I didn't want to be an employee or an employer. And I know Davin had talked about, if you're working for someone, there's always like an incentive because they're making a cut. For me, it was worth it because I felt like I don't have a business acumen. I don't want to hire and fire and figure out the lights and the bills. I just wanted to focus on the patient. And unfortunately, I was in a family medicine practice residency, which, like many, did not have much business training, education. So I maybe if I did, I would have chosen different. So number one, I didn't want to be an employer. Number two, I knew I could hang my shingle and say, I'm the best integrative alternative medicine doc out there. I'm going to charge, $1,200 for a consult. That goes back to what, Erik, you mentioned in your session about if I did that, I would be only treating the more, advantageous, entitled, maybe worried well. And I said, integrative medicine should be for everyone. And so I wanted to stay in an insurance model. Mm-hmm. And there's definitely negatives to that, things that aren't covered. But I felt like I wanted to, I wanted the rheumatologist, I wanted to convince the specialists that number one, it's safe. Number one, I'm going to make your job easier. You're going to send me that rheumatoid arthritis patient, and I'm going to help their diet. I'm going to help their mindset. I'm going to help many things, which then they're going to come back to you. Hopefully, best case scenario, you're going to need to prescribe less steroids, less injections, see them less often, and really just be there as needed, which is how specialists should be, as opposed to more procedures. So for me, I wanted to I had that, chip on my shoulder to be able to do it in a more multi-specialty, maybe academic you could call it, but more multi-specialty. And I also wanted to help patients who maybe were hesitant to be like, I'm not going to go to that acupuncture clinic on the corner because it looks weird. But if it's someplace my rheumatologist told me to go, and you're an MD, and you're guiding me, I'm going to help introduce that world to that population. So that's why I wanted to stay here. And many opportunities have come to jump ship. And I think for me, because I like those two challenges, I like to do research, which also is part of my practice. I think that's a model that works for me. But I have many colleagues who absolutely would never want to be in this setting. They want to be their own boss. They want to do concierge. I totally get it. And that's one of the great things about medicine. There's still, many opportunities there. But that's a little background of why, I stayed. I continue to love being here.
That's awesome. Maybe speak a little bit then to, I'm sure that they talk to you about the financials and how well the clinic is doing. Maybe you can speak a little bit to that. And has it been a challenge? Have they needed to, kind of rob Peter to pay Paul by keeping you guys alive? Or are you guys solvent and you're making money and you're showing that this is a very, valid way of billing insurance and approach to medicine?
Yeah, that's also a great question, because as you and I both know, there have been some incredible docs who are incredible integrative and functional medicine gurus, but their clinic has been shuttered. And we know many clinics that had a nice little donation that didn't transition to an actual working model. And I think what my mentor, Dr. Guarneri, learned very early on was you need to have a high-tech, high-touch approach. And you need to have something like we have from very early on. We had an imaging center, which was for early detection of heart disease, cancer, et cetera. So that while that's churning, we can help offset the cost of that yoga class, which we're in La Jolla. So you can't do enough yoga classes to pay the bills. So you're going to go out of business. So our model was high tech, high touch always to balance each other out, knowing that some of just like primary care can be a loss leader, you need it. It's beneficial for patient care, but it's not going to keep you in business unless you have something on the other side. And we luckily had imaging and we continue to thrive in that area. So I'm not saying that's the only model, but there needs to be a balance. And so over time, that gave us time to figure out how do we bill acupuncture to at least, pay for. It didn't make sense for me as an MD to do all the acupuncture. So over time, we hired acupuncturists who were very adept at working in a medical model. We hired biofeedback therapists. It didn't make sense for me to do that versus consults and procedures. So we need to have a team approach. So we learned that, but we had the backing of the imaging to help us not lose money. And so when we presented to the executive board of Scripps, they may be a fan of yoga and massage and acupuncture, or they may be neutral, or they may think it's hogwash. But what they knew was that the center was thriving financially, or at least was break even. So it was paying for the basics, and there was enough patients who were going back to their doctors and the board to say that this is why Scripps is different than the Kaisers and the UCSDs, et cetera. And luckily, those other centers have also brought on integrative medicine. Some have failed, some have made it. And that's the problem. The financial model for integrative medicine is you have to kind of start fresh with each model based on your leadership. We had good leadership to support us. And if you don't have that, it's very hard, as you know.
Yeah, absolutely.
That's staying on this theme a little bit. Is there a large capitated population there? Because I could see where that might also help, right? If you have, a per member, basis payment coming in, and you're decreasing maybe the cost of specialists and referrals, et cetera.
Yeah. No, we're in, Scripps is in a few ACOs, accountable care, and models where there is, monthly fees that come in for overall care of the patient. And we had looked at, Cleveland Clinic, as part of the Cleveland Clinic Foundation. They have an integrative functional medicine model, and they actually did a JAMA study. They had the health epidemiologists to be able to say those folks who traveled through their integrative medicine, but then ended up needing to go for other care over the next year or two had improvement in their stress, their heart disease, et cetera. We've never been able to figure out how to do that within our system with the 5 hospitals and such. But I think those kind of models are the best way to show that if you embed integrative medicine versus send it out, it actually makes the most sense. Even though you're paying for us to be here, it's with, you keep everything within the system, and it makes the job of the surgeon and the rheumatologist a little bit easier. So we are part of that. And I do think in general, even though we don't have like hard reported numbers, we've seen that over and over again, and patients reported back to that help to keep us here. I mean, there, in some ways, arguably, you could use this space to make more money per square foot, and that has actually been mentioned at our board meetings. However, I think having been here 25 years, they see the overall benefit to the patient population and the community. So luckily, that's not an easy thing to sell, but they've seen it.
What does that look like in terms of the number, right? I mean, because you're still volume based. So what is it looking like in terms of the number of patients that you have to see? It sounds like you've started to leverage some of your experience and knowledge and bringing in other ancillary providers to offset your direct involvement with patient care. But what does that look like on a day-to-day basis?
Yeah. So it's important for a lot, if there's an young integrative medicine doc or a doc that's in practice who's thinking about going to integrative, number one, you don't have to necessarily do those therapies. You don't have to be the acupuncturist and the biofeedback therapist and the massage therapist, et cetera. What we learned is in a lot of the models, PPO models, insurance models, you can be the oversight clinician. So today, as I'm here, we have several acupuncturists who are doing their skills. They're doing their bill. I'm doing co-signing, and I'm submitting the bill as the MD to, the Health Net and the Blue Cross Blue Shield. So
much like a respiratory therapist, would work under a pulmonologist, right? And the pulmonologist doesn't need to do the actual therapy themselves, but they can bill for the services because they're supervising and overseeing it and prescribing it.
Right. So I'm overseeing the acupuncture. I'm overseeing the biofeedback. And so that allows me to do two things at once. So I'm seeing consults. I'm very fortunate. I have up to an hour for a consult, up to a half an hour for a follow-up. That's very generous across our clinic, but arguably that's what you need to get the full picture. But in that 30 minutes or 60 minutes, my staff is doing other things that are billing and helping my RVU and the clinic RVU. Other clinics, unfortunately, I wouldn't say unfortunately, but each of those clinicians bill on their own. The problem becomes okay, you have acupuncturist A, they're not under Health Net or whatever. And you need to go through that whole process for each of those additional providers. Whereas I've been here 25 years, I'm already in all the insurance and I'm doing the billing. Legitimately, I read all the notes, I co-sign. If there's an issue, I handle it. So that's the way that I think we've made it work, as opposed to the one-man band, which is a real good formula for burnout and hating integrative medicine, because you just are trying to do 5 jobs in one, and there's no team. And I think that's one of the issues that I think is unfortunate for our field when that happens.
Yeah, absolutely. We had Michelle Leary on. You may know Michelle from IFM a few weeks ago, and she talks about how they've started a membership model in conjunction with their insurance. Is that something that you guys have looked at, explored at all yet?
No, I think it's a great possibility. It has been brought up in the past of like, okay, you have the typical Scripps patient, and they find out about the Integrative Center, and we have a fitness gym, we have a cooking, teaching kitchen, we have all these classes, yoga, Zumba. And so it's almost like you're adding the whole wellness aspect to it. And maybe there should be a membership. Unfortunately, it was too difficult to figure that out over time of like, what does that entail? So we do have just you pay per class, and that helps Scripps. Again, I think at the end of the day, that is it really worth it to create a system where those classes are not real moneymakers? Then Scripps does have concierge care, which is more like an executive health model. We have never been pulled into that. That could be a very interesting model. I think some centers, their integrative center is sort of the concierge within the system. But because that's a different location, and for other factors, we weren't. So we don't have a membership model. We don't have concierge. I think part of that is because Scripps is still sort of pretty much a fee for service. And the clinicians are still RVU based, I would say, except for some primary care. I like the model more like Cleveland Clinic, where it's a salary. And I think you might have bonuses if you go, outperform that. But at the end of the day, you're not still hustling for RVUs to do more to more patients, which is still, one of the unfortunate parts of that model where there's less incentive for really getting to know the patient and doing less. So anyway, I think there's improvements to be made within this model and similar models, in my opinion.
Yeah, I was part of a large health system, and literally I left less than 2 years ago, and I was still on a completely RVU model, right? Like no base salary, nothing. You just eat what you kill, as they say, right. Which is a strange term to use in medicine, but right. But yeah, so that I can relate to that, and that was also part of what drove me to finally leave, was that it's hard to be in a model where you're actually you want to spend more time and you want to do less to the patient,
right.
In one of those models, and so I think it's great that you found this niche and that you had the leadership that you did. It's really impressive, honestly.
I feel blessed, and I think, like you said, we all kind of got lucky in our own way. Sometimes a little bit of burnout, so kind of lights the fire to find something else, or lack of a job. So, I just happened to land in the right place, and I think regionally, I was lucky. If this was another city, may have not been as fortunate. So.
Yeah. I'm wondering if that labyrinth is sort of like the red pill, blue pill in the Matrix. Maybe I need to go.
Yes, it's available. It's about 100 yards. I'm happy to tour you. You can ask your intentional question, like Erik mentioned. He'll actually be your guide because it's worked for him as well. So, yeah, one of your podcasts, maybe you'll film on location here.
Yeah, you'll be happy to know that as we're building our home, we're going to be putting a labyrinth on our property. So you'll have to come visit us, and you can walk the labyrinth, and I'll set your intention right so you walk it appropriately.
I can already see the root cause podcast retreats happening at your place. So watch out what you intend, because it's I think it sounds like you're going to expand this discussion and hopefully be able to get more people to visit their labyrinth, whatever that looks like in their location too.
Well, let's shift gears. Let's shift gears just a little bit, Robert, because I wanted to also explore one of the things that you have done as part of your career in integrative medicine has been through education, right? So maybe speak a little bit to, what kind of got you to write a few books. Let us know what, helped you get into, you've co-hosted conferences, you participated as a speaker in conferences. Maybe speak a little bit to that as part of your either career enhancement or just, what inspired you to kind of move in that direction and add that to your already busy clinic repertoire?
Thank you for bringing that up. I recall, I think education started with realizing that patients really wanted that, didn't know how to ask. I remember as a resident, there was a patient with some prostate issues, was going through surgery, and I was doing a late night rounds on him as, the resident or intern. And I just said, hey, what else are you doing to help you through this? And he looked at me like, what do you mean? I said, are you taking any supplements? I know some patients, take that as they're going through this. And he goes, oh my gosh, didn't want to tell my oncologist, and, my other oncologist yelled at me. So he brought out this huge bag and I was like, whoa, what is that? And he just showed his wares, sort of like. And I was like, wow, there's such a disconnect, and there's not a lot of education on how to talk to each other, both on the clinician and the patient side. B, what to do when that's on the table. And so it's sort of don't ask, don't tell policy. And I said immediately to myself, this is something that needs to change. And I think we've all had that thought, so that one clinician doesn't for lack of a better term, hold the whole bag of all the supplements or whatever it might be. And so my grand rounds, we all need to do grand rounds as a senior resident. And I was really nervous about it. I didn't do a lot of public speaking at all. And I said, I'm going to do it on herbal medicine, safety, interaction, potential for benefit. And I did it for my whole hospital staff. And I thought, oh my gosh, they're going to throw tomatoes at me and pitchforks are going to come out. And it was like so thoughtful because everyone was like, yeah, I was worried about those interactions, or wow, I never thought to ask my patients about that. And so I think that made me think like more education needs to happen. And even though I don't like public speaking, I'm going to try to do more of it. So that led to more. When I started Scripps, I started the Natural Supplements Conference, which you've spoken at, and now we're working with UCI, a bigger entity with more resources. As you've also spoken at that, to help get this idea that, we don't just need education on how to help the kidney or the heart. We need to help education on how to talk to patients, especially on topics that mean a lot to them, like lifestyle, diet, et cetera. So that's where the lecturing came from. And when I go on stage, I'm nervous. I may not look as nervous as that first time, but I'm still nervous. But hearing back from clinicians makes me want to keep doing that. The books just were the next step of that. Like, I can do one lecture here, I can do one lecture there, but if I have a book, and both of my textbooks have been editorship, so I just bring in my friends and people who also like to write and educate. I can tell you that's not a moneymaker at all. So when I get my $6 royalty check from Lippincott or whatever, I show it to my kids and I tell them this is not going to pay for anything. But I enjoyed it. It was fun, and maybe someday I'll try to write a book to the consumer, and that I think is a better way to do it from a financial standpoint. But education, I think, it's so powerful to help level the playing field. And actually the introduction to one of my textbooks was that scenario with that patient. I was like, if we don't have education, we're going to get stuck in that late night, shame session of like, oh, I didn't want to say anything, but here, and that's not really helping a patient long term. And so I think that's where education comes from. And I know part of what you're doing here is educating other clinicians about here's opportunities, here's how to overcome challenges. And I really applaud that.
Well, you have come a long way from those early presentations in front of Stuart Rugg at Occidental.
Oh, yes.
Remember?
Yes.
He would make us get up
God.
and share a paper or something that we had read.
Yes.
I remember just
he treated us well.
as you would stand up there, I was like, oh, I wish I could just go up there and give him a hug or something, because it looked like you were having a stroke or something.
Yeah, I think I was. I mean, stroke, talking about some of the topics that we knew Stuart already knew a lot about and could make us look like a complete idiot, which sometimes happened, but he did it in a kind way. And I think he prepared us for what we know as pimping when we're interns. So it was early pimping in an undergrad setting, I guess.
It was awesome. He was such a great mentor for us, for sure. I think, he, in a lot of ways, prepared our minds for functional integrative medicine, right? I mean,
Absolutely.
We thought about the body and how it performs in its optimal state of performance as not as something just athletes do, but actually as a goal for every human being. And I know for me personally, it was really inspiring, and it really, I struggled when I got to medical school because it wasn't what we were being taught by Eric Sternlicht and Stuart Rugg and others that were really helping us think about what was happening at the cellular level.
Yes. To add to that, in medicine, we often have models of clinicians who are do as I say, not as I do. So it's sort of, for just a simple example, the cardiologist who's overly stressed and eating poorly and, telling the patient, this is what you need to do, but, they're not doing it. So Stuart, on the other hand, not only lectured it, but he was actually a living embodiment of this is what this can look like. And then the other thing he did really eloquently, which a lot of professors don't do or can't do, was connect the dots between, physiology and then diet and lifestyle, go outside the classroom and connect it to your other topics and classes. And so he, I think, was an integrative thinker and professor, and allowed us to be like, oh, okay, so I can go to the philosophy class, but also talk about, Eastern thought and, physiology. And I think he allowed that opportunity, whereas in academics, sometimes it's very rigid, siloed, and makes it difficult to another model to that has to be broken, I think. So make sure you, hopefully when this hits YouTube, you can share it with him, and he can make some snarky comments about us.
He will love it.
Yeah, I think about him from a longevity standpoint too, right? I mean, at his age, he was in such amazing shape, and then also just organizing those trips to the Yosemite and other things, right? And I think he did sort of teach us that complete it was a lifestyle, mindset, starting with mindset. And I wanted to kind of double click there a little bit with you, because it sounds like even teaching for you comes from just a place of true caring and like wanting to help and wanting to share important information, which I think now I sort of view that as a way to that type of intention, I think, increases our own frequency and kind of the energy that we're emitting, which I think is so critical to this type of care, that we're generating an energy that people can just benefit from being in that environment. And I wonder if that obviously in maybe the Eastern experience and others, but how does that play into your practice as well, in terms of what you do?
Yeah. Well, no, thank you for that. I think in medicine, I mean, we all know the old adage that, doctor comes from educator and teacher. So that being said, I think being a doctor, it's hard to be an educator because it takes time. You kind of have to feel confident in what you're sharing. It also, the best educators are good learners. They don't stand on a soapbox and say, here's a good diet. Your diet sucks. And so, a lot of times when I see a patient, I see a lot of migraines. So that tends to be my more of my specialty these days. And I can't tell you how many, patients like you've seen who sort of get pigeonholed. Like this is the only way to teach or treat migraine, like this medication. That doesn't work. This medication. That doesn't work. Let's try this injection. And it creates a passive model. So education is the cure for taking a passive model of care into an active model of care where the patient is a big part of the solution. So, when I talk to patients about their gut health with migraine, like, I've never heard that before. How can you, as a migraine patient, I'm thinking this, like, how have you never heard about the microbiome? And not in a shameful manner, but like, I have so much to educate you about. I have so much that we can help you with. And did you know if you increase your fiber by 10 grams a day, that reduces your potential for migraine by 10 to 20%, on par with drugs, and not to say that it's either or. It's usually like, let's expand your toolbox in a way that makes sense for you. And it might be same with exercise. Here's a way to use exercise to help your migraines. Never heard that. I thought it was a trigger. So when you see that light bulb, I think that's the reason I do it consistently. You don't get it, in every visit, but even if 1 out of 10 patients says, oh my gosh, I'm motivated to try that. And it could be a new diet, a new neurostimulation model, new treatment. It could be just anything that sort of expands their toolbox to feel like they have ownership and active view of their future. That's better than any any raise. Not that we get any raises in medicine, but it's RVU, but it usually goes down. But that's better than anything, in my opinion. Going home and telling my wife, I had this light bulb moment in my practice. And I think you guys, I'm sure, know what I'm talking about.
Yeah. And maybe you can elaborate a little bit more, because obviously one of our goals in doing this podcast is to help create a different approach to medicine so that we're not experiencing the burnout, right? And you had mentioned that at the beginning. can you just maybe expand a little bit on what do you do? It sounds like this is one aspect of your practice that helps rejuvenate you and stimulate you in a positive way. But maybe you can speak to what are some of the things that you're doing? You're still in an insurance-based, system-based, somewhat academic setting. So what are you doing to keep from burning out?
Yeah. So I think part of that is, like you said, those highlights in your day, but that in of itself is probably not going to help if you're in a really bad environment where you're being told, you see more patients, you're not really doing good work as far as for the system, even though you might be helping the patient. So I think from a burnout setting, part of it is remembering internally when I'm seeing the patient at a light bulb moment is savoring that. Like that might happen twice a day, once a day, and sometimes I'm still like, oh, Epic just crashed for the third time today. And, I'm behind and my patient's late and this and that, right? All those things, you don't want to savor those happen, and you kind of try to flush them and then go back to that patient that you can savor, or that moment that you help somebody. So that's part of it. And also teaching others how to create those moments of savoring and improving their practice. So as you know, through your work at UC Irvine and, teaching at the fellowship, we're helping other clinicians who have not lost their way, but are looking for rejuvenation in their practice. It could come financial rejuvenation. How do I better bill? How do I do group visits? How do I do infusions? Things that really transform care. For me, I go there and I do new ways to do patient interviews. And Dr. Lodog, Tehran Lodog, one of our good friends, and I work on that together. So instead of saying, what's wrong with you today? Oh, you have a migraine and you've tried everything. It's like, what's going on for you that's important to you that we can get back to? What are you missing that we can get back to? Oh, you missed playing with your friends or going to the movies because of the migraine, or other things that are their why, sort of like, why are they, coming to the clinic today? It's not just to get rid of the headache, but is to get rid of the headache to be able to do something else that is kind of they've missed. And I think trying to help patients find that, and helping other doctors reframe how they've been doing their history and physical for the last 15, 20 years, because it's based on a pill to the ill model, also gives me some prevention in my burnout when I go back and say, I helped 12 doctors, and they told me, like, that's a whole different way of doing it, the H&P. So that's part of it. And I'm sure you get a sense of that when you see those fellows and they're like, I never thought about billing it that way. I never thought, I didn't know I could do that. And that's the inspiration. I think the last thing I would say is I try to do Tai Chi every morning in my backyard, whether it's for 3 minutes, 5 minutes, sometimes longer. When I go to conferences, sometimes I teach it. I do a little Substack. It's called The Power of Pause. Little things I write at Oxy. I was I did a lot of writing. I did collegium, which was, I had to publish a book of poetry. And again, that's another thing that gets kicked out of us in med school. Like, it's all about reading the abstracts and do that. So what do you miss from your earlier days? For me, it was writing. So I started writing. I'm on Substack. I probably have 10 subscribers. It doesn't matter. I still publish it. And I think finding avenues where you help the bigger you, not just the medical you, feel like you have an outlet, whether it's education, poetry, dancing, Tai Chi, playing basketball. That's what I think is the real key to helping patients, doctors and clinicians not burn out.
I love that. Yeah, it's practicing what you're actually teaching, right? And living the lifestyle that you're trying to get other patients to live. But I love that. I think that it's key to our success as physicians is that art of medicine, and not just cultivating the art of how we approach medicine, but cultivating the artistic, creative aspects of ourselves, our own persona, which I think is awesome. And you'll be happy to know that in the past several weeks, I have restarted Tai Chi, and I have been practicing a little bit on my own and finding it very helpful. So we might have to have a little video session of us doing some Tai Chi the next time we get together there, Rob.
Absolutely. Absolutely. I look forward to maybe some of your videos on YouTube as well, as along with the podcast. So
Erik, do
no.
you do Chai Chi with a pickleball racket in your hand?
Yes,
I'm
you know,
curious.
this. I got the pickleball paddle
Work
up and
off.
floating
Yeah.
it across, and
I
you know, I've
hear
got
Erik is
instead of a
maybe both of
moon,
you.
instead of cradling the moon, I'm cradling the pickleball, right? So
I have never played pickleball, and it's one of those things I would love to. I used to play a lot of tennis, and I think it's in my future. But it's one of those things like once you jump over that fence into pickleball, it's sort of admitting certain things. But maybe not. Maybe it's a bias I need to get
I will
over.
tell you, Rob, it's like going from conventional medicine to integrative and functional medicine. Once you cross over, you never go back.
All right. Well, I look forward to sharing that as well with you guys. Some pickleball.
That's
next
awesome. Well, we're coming up on our time here, and I know Davin has his favorite question to ask, so I'm gonna let him bring us home here and get in his last question.
Well,
here.
I'm gonna modify it slightly for you. As we ask people where we kind of see what is the trend, where do we see functional medicine, integrative medicine going into the future, and maybe you could layer in a little bit of AI and technology and how those might come together to sort of guide the future of functional medicine.
Yeah, no, thank you for bringing that up. I know it's an area we have mutual interest. I remember in residency, we had practice partner. I don't know if they're still even around in the clinic, and I would go to the hospital and there was no electronic medical record. I remember taking out my Palm Pilot, which makes me feel really old, connecting it with like a 16 prong to the printer and trying to, and I was like, there's going to be a future here. And I still think in some ways we're trying to figure it out. And I think AI is one of those things we have to rein in some ways. It's beautiful when we can get a quick answer through ChatGPT or whatever model we use that can, help us get to the answer that's really our answer, but it's stuck, in this realm of too many other things in our mind. So I think the future, to get to your question, is, functional medicine is so complex. And I think, microbiome testing, heavy metal treatment protocols, and like all those things we're trying as these functional medicine, integrative medicine docs, trying to figure out, okay, for this patient and all their complexity and all their data, how does that interrelate? So I think there are models, just like we're seeing in other conventional care models, like using AI for better detection of breast cancer and better personalized treatment. I think AI, although the models I don't think are quite there yet, to interplay with good clinicians who really want to use it for the right reasons, can help us create the best, personalized portfolio. I think right now there's also issues with, as there should be, because it's a business, right? What's the best model and what's the cost for that model? And the free models are there, but they're not always giving you the most accurate answers. So I'm hesitant, but I'm also very hopeful, in using this. So I think part of the solution would be easing our brain, our fuse, to keep it for personal interaction, human interaction, because an AI model can try to be kind and patient, but really it has a human trait. So if there's a way to let AI do what it's best at with guardrails and letting the human, the doctor, be the educator, the actual doctor, I think that's the future. And that potential is there. There's a lot of bumps in the road. I know that's a very general answer, but I'm still looking for that model, as we all are, and I think it's going to be there within the next few years to help us. So I'd like to hear your thoughts as well, Davin, on that front. I know you've done a lot of work there.
Yeah, I would agree. One of the companies I worked for, we were using AI for scribing, and we had a board member, and he shared with me one day before we did a little panel of how one of the founders of AI, like way back, like in the 60s or something, like when they were just beginning to imagine this, right, had said that the goal was really to create something complementary to the human. It was never to replace the human. And so I love that that idea, right? Of let's allow technology to give us time to be more human, and that would be the perfect marriage of the two, I think.
Absolutely, well said.
Well, this has been an absolutely wonderful interaction with you, Robert.
Yes, thank you.
And you have become a amazing presenter and educator on stage. So you've come a long ways from those Occidental days where we had to stand up on sometimes on the cuff. He would just say, "All right, Robert, get up here and tell us what you know about whatever," right? And it's so wonderful that you are passionate about educating, because you do such a great job of it. I've learned so much about the realm of pain management and how the interplay between the nervous system and the gut and the brain and the toxicity that we get exposed to all plays a role in that. And I appreciate your insights into that as I take that into the patient-physician interaction. But thank you for taking the time to be on our podcast today. And we look forward to how things continue to evolve.
Absolutely, my pleasure. And I feel so fortunate to be here on the ground level, so to speak, as you're getting started. I know there's a ton of podcasts out there, but your topic, your focus, and obviously how you two are interacting with folks who, gone through a lot of their own journey to share that. I love hearing about your journey that you guys have shared and listening to other journeys. So keep up the good work. I know it's going to catch on, and I look forward to the day I can say, I knew them way back when they weren't as popular as Smartless or some of the other podcasts. So just let's remember that. All right. So good luck, and thank you again for having me.
You're so welcome, Robert. We'll remember you when we have our hundreds of listeners.
Absolutely. You guys take care.
All right. Thanks.
All right.